This video will be an overview of interstitial cystitis. First, we will go over an introduction of interstitial cystitis, then review the management, explore the role that nutraceuticals play in management, and overall conclusions. Interstitial cystitis / bladder pain syndrome is a diagnosis that applies to patients with chronic pain associated with the bladder in the absence of other explanatory etiologies. Bladder pain can be described as a pressure, discomfort, or spasms in the suprapubic or urethral areas. This pain can be constant and vary on a daily basis in timing and severity. Those with IC will typically have relief with voiding, but pain when the bladder distends, causing frequent voids to avoid discomfort. This is in contrast to overactive bladder, where patients void frequently due to urinary urgency but without pain. IC affects women worldwide, and the Rice study concluded this number is between 2.7 to 6.5% in the US. In those with IC, it has been found that patients have higher serum and urine levels of cytokines, such as those listed. Some people are able to identify triggers for their symptoms, while others say their IC developed after a UTI or trauma. In terms of triggers, there are certain foods that are commonly found to trigger IC flares, such as coffee, tea, soda, alcohol, spicy foods, citrus, tomatoes, etc. Foods that tend to be more acidic are more prone to being a trigger. Other triggers can include stress, exercise, sexual intercourse, and prolonged luteal phase of the menstrual cycle. Understanding the anatomy of the bladder is crucial in understanding interstitial cystitis. The first layer of the bladder wall is the mucosal layer, which contains the transitional epithelium, which allows stretching of the bladder wall. It also produces glycosaminoglycans, also known as the gag layer, which protects the mucosa from potentially inflammatory irritants in the urine. The submucosa further allows bladder stretch, since it's made of elastic connective tissue. The detrusor muscle produces a simultaneous contraction to effectively empty the bladder. The last layer of the bladder is the fatty connective tissue. The underlying cause of IC is unknown. However, there are many theories as to the pathophysiology. The most prominent proposed etiology is a defect in the gag layer. Other proposed etiologies include an abnormal activation of mast cells, high-tone levator dysfunction, perceived to be related to the bladder ischemia, autonomous nervous system with afferent sensory hyperactivity, and submucosal microvascular abnormalities. One or a combination of these can lead to an increased discomfort through a few possible mechanisms. One being that a disruption in the urothelial barrier can allow noxious stimuli in the urine to irritate the bladder. Defects in this barrier can activate the underlying nerve and muscle tissue, which may promote further tissue damage, pain, and hypersensitivity. Another mechanism explains how certain foods might lead to more irritation than others through the GI tract. The irritation of the GI tract can cause a neural crosstalk theory, stimulating nerves in the bladder that irritate it, leading to the symptoms experienced in IC. When a patient comes to the office experiencing the symptoms described for at least 6 weeks, performing a physical exam is important. Patients may experience variable tenderness of abdominal wall, pelvic floor, hip girdle, bladder base, and urethra, and or tightness or tenderness of pelvic floor muscles. Some differentials to keep in mind when a patient comes in are infection, stones, lower urinary tract cancer, leiomyomas causing mass effect, chronic pelvic pain syndromes, and other neurologic conditions. When making a diagnosis, it's first important to get a good history to even make this diagnosis of exclusion. Questions such as, are they having symptoms of urinary frequency or urgency? How long between voids? Their nighttime voiding frequency? Is there relief with voiding? Are the symptoms bothersome? Are they sexually active? Do they have pain with intercourse? Any prolapse symptoms? Are they on any medications like diuretics? And obtaining their obstetric and surgical history are imperatives to ask. Symptom questionnaires like the BPIC-SS, which is what ACOG recommends, can be helpful in qualifying symptoms. From here, doing a UA and post-void residual is important to rule out other causes. If a urine culture is done and it is sterile, this can further support the diagnosis of IC. Cystoscopy is not required for the diagnosis, but if performed, can show Hunner lesions, which are highly specific to IC and identified in 5 to 10% of patients, or glomerulations, which are petechial red areas seen after hydrodistension, which are not specific to IC. Glomerulations can be found in 45% of the population, but if greater than 10 glomerulations are found in 3/4 of the quadrants of the bladder, it increases the likelihood of the IC diagnosis. On biopsy, which is very rarely performed, people with IC can have increased mast cells in their bladder. In terms of management, if you are unsure of other etiologies, doing a cystoscopy to visualize the bladder is important. Otherwise, first-line treatments are lifestyle modifications. This includes stress management and general relaxation, patient education, and behavioral modifications including dietary changes to avoid trigger foods. Second-line treatments include pelvic floor physical therapy, oral medications, and intravesical installations. Pelvic floor physical therapy can also be useful, especially in cases where patients have pelvic floor spasm and myalgia on exam. Medicines such as amitriptyline and other tricyclic antidepressants can help with pain. Pentosan polysulfate, also known as Elmaron, can help to reconstitute the gag layer of the urothelium. However, it has been associated with maculopathy with long-term use. Antihistamines such as hydroxyzine can help, given the hypothesis that increased mast cells in the bladder wall are contributing to IC pain. Other medications may help, such as phenazopyridine and Preleaf, which can help relieve urinary symptoms. Third-line treatments include cystoscopy with hydrodistension and treatment of Hunner lesions if they are found. The mechanism behind why hydrodistension relieves symptoms is unknown, but is thought to be due to the disruption of sensory nerves within the bladder wall when the bladder is distended. Let's delve more into the types of nutraceuticals available. Nutraceutical is a combination of the words nutrition and pharmaceutical. They are a formulation of nutrients that prevent and treat disease. Calcium glycerophosphate, also known as Preleaf, reduces titratable acids in foods. L-arginine works by increasing nitric oxide, which can work as an antibacterial and smooth muscle relaxant. Mucopolysaccharides can act as gags and protect the urothelial lining, as mentioned before. Desert Harvest freeze-dried aloe vera is commonly used by urogynecologists and urologists. It has been shown to effectively reduce bladder pain and can improve day-to-day life for patients. Bioflavonoids found in foods can be broken down into quercetin, which can inhibit histamine release from mast cells. Lastly, Chinese herbs have been found to decrease pain symptoms in patients as well. After starting a regimen that helps with IC symptoms for the patient, we can assess their pain at follow-up visits with standardized questionnaires such as the Genitourinary Pain Index Scale and monitor progress from there. If pain is still uncontrolled, we can consider fourth-line treatments such as intradetrusor Botox injections and sacral neuromodulation, fifth-line treatments such as cyclosporin A, and sixth-line treatments such as urinary diversion or cystoplasty. Overall, IC is a diagnosis of exclusion characterized by chronic bladder pain or discomfort. Therefore, getting a good history is important to rule out other causes. Early options for management include lifestyle modifications before more invasive management. Nutraceuticals can play a role in managing chronic pain, and it is important to perform a cystoscopy if the initial management is not helping in order to evaluate for other pathology or presence of Hunner lesions. Thank you for listening to an overview of interstitial cystitis.